Welcome back to Dental Talk 360. In today's episode, we will be talking a little bit more about occlusion, the functional aspects of occlusion, and why it's so important to understand the basics of occlusion in order to do proper treatment planning for our patients. Occlusion, simply said, is not just the way teeth fit together, but it's also the way our jaws move. This is really important to understand how they both are synergistically affecting the way we should be diagnosing and treatment planning. So let's talk a little bit about occlusion and the different types of occlusion that exist and how we can gear different types of treatment planning accordingly.
Fetty, I'm gonna let you go with that. So Fetty and I are COIS trained, so we're gonna just summarize how we see occlusion.
Yep.
Bart is, I don't know what trained.
And clinical
Mastery
mastery.
Clinical
series.
mastery, so he will teach you his way.
It's the same thing, basically.
It's the same thing. It's all the same crap.
So let's start with the basics. Everyone is going to get that patient that's going to come in with worn canines, cupping, enamel fractures, enamel wear, enamel facets, wear facets. We need to understand why those things are occurring and their full envelope of function. So a couple mindsets when looking at things are MIP, maximum intercuspation. That's in COIS training our ideal position to restoring a bite. It's reproducible. Most patients go in there left and right. In clinical mastery, if I'm not mistaken, you guys use more centric relation, using CO or centric occlusion, which is the first point of contact using leaf gauges as their set point to create the bite. What are the differences? Listen, we could talk about this for hours. And this is a topic of controversy all throughout our profession. So whether you restore an MIP or CR, as long as you're understanding the basic fundamentals of restoring a case and seeing the wear patterns and understanding them. So you might have a patient that has a chevron pattern or a triangular wear in the front teeth. That's a side-to-side movement, crossover wear. Understand, you can't lengthen that person if you don't take care of them, because what's going to happen if you lengthen those front teeth? They're going to break.
Same thing.
Yep. The same thing's going to happen. If they have no canine guidance on either side and all their front teeth are chipping, you know that you have to recreate that canine guidance, right? Whether it's an MIP or in CR, it's the same, right? That's a very important thing. When people do an FMR and there is no guidance on the posterior, either with a canine or sometimes on patients, it could be on the first premolar or even a second premolar. And that's where they go because of their jaw movements. But always making sure that there is relief in the posterior occlusion at some point. And also when they go into protrusive, that when they go into protrusive, they're not hitting the back teeth at any point, because that could lead to problems. So when they go forward, they're edge to edge, the posterior is relieved. That whether it's in CR or an MIP, those things need to happen. Also making sure that they're not hitting their inclines of their cuspids or in their molars. The occlusion should not be in those inclines. They'll have pain, I guarantee it. Bart and I do plenty of leaf gauge stuff, and if they're hitting on those inclines in their molars or in their premolars, they're not going to be happy. So understanding where your occlusion points are, there's plenty of models that you could look up online that give you ideal contact points. Study them. They're pretty basic. I always tell people, the lower teeth, the molars should hit in the buccal, on the buccal cusps. The upper teeth on the lingual cusp. You don't want them back and forth, right? Avoid the inclines, making sure you have bilateral cuspid, and very minimal contact in the anteriors when you're restoring a case to avoid trauma or fremitus that can occur if they're in hyperocclusion. So these are using leaf gauges, whether you're using artisan foil, AccuFilm, or the thicker, which I'm not a really big fan of. I'm more of a fan of AccuFilm and artisan foil to really minute check things. But, you know, those things need to be done. And I use, for example, the iTero to my benefit, which a lot of people don't. I deliver a case, I do an iTero scan, and I look at the weather map, if you will, or all the red, orange, blue, all the colors, and I look at to make sure that there's no red areas or orange areas, which normally are very tight bites, and use it as your cheat sheet to make adjustments to your bite. And you're going to see that the patient's going to have a lot of relief, and it's going to make your clinical workflow so much faster.
Yep.
And then you could double check it with your articulating paper, but we have so much technology that we could use to our advantage in occlusion, right? So, but number one, looking at those wear patterns. Are they a class 1, class 2, class 3 patient, and understanding how the wear patterns normally occur on those patients, how far you can open their bite on those patients. So for a class 1 patient, you could open them up more than you think. If you think about an edentulous patient, they have no bite. You are essentially opening them up 30, 40 millimeters. So if you're opening them up 3 millimeters, you're gonna be okay. On a class 2 patient, if you open them up too much, normally over 2, you may have some TMJ problems. So watch out with the class 2 patients.
Great points, Freddy.
And on the class 3 patients, 1 or 2 millimeters, you'll jump their bite very easily. Last point to help you out, take a CBCT scan of their condyles. If they're pointing backwards, you're over closed. If they're pointing forward, you're over open. If they're right in the center, north-south, you're in the sweet spot. So that's how you double check all of those things to make sure that your occlusions are on point. Very simple thing, and we look forward to showing you more in the future. So give us some pointers that you'd like us to touch more base on this, because this is a very big topic, and we just kind of wanted to give a brief
And
overview.
I want to say one of the most important parts of occlusion from a dentist standpoint is being able to properly articulate that to a technician. So record keeping is one of the most important parts of all of this as well, in addition to
Yes.
understanding what we're looking at. So can we touch a little bit on that? I know Oscar and Bart have amazing insight on that. They're just
I'm gonna let
itching
Vince
to
talk
talk
because
about
Vince has
it.
been itching to talk. The first 2 minutes were Fetty, so luckily
I
I only
retired.
had
I
15 minutes, and Fetty just destroyed it all.
He has so much
So I don't know if
knowledge.
I'm supposed to fucking talk about it anymore, but he looked like he wanted to say
The
something. So
one
go
thing
ahead.
about occlusion, which
Yeah.
you said it's a controversial topic because there's so many different trains of thought, and they will die on that hill that they are right.
Yeah.
The one thing that we have to our advantage for 95% of the population, that TMJ joint is extremely adaptable. So if you are close, now you want to aim for perfect, but if you're a little bit off, usually that person's teeth, they can grind a little bit. That joint will adapt to a spot. Is that what you want to aim for? No. But the topic of occlusion gets super overcomplicated because there's so many trains of thought that when you go learn them all, you're almost worse off than when you didn't know because now you have all this information. So it really comes down to, you mentioned it a little bit, where it's, think about the teeth and the design of the teeth. The back teeth are built, they're bigger, they have more roots, more surface area. Those should probably get the most contact. And as you come forward, you have sharp teeth that you want to build guidance on. Utilize the inclines of the cusps. And how much do you have to get clearance on the back teeth? Just enough.
Just enough.
Just make them not hit.
Yeah.
You can simplify it, which will work on 95% of cases.
Correct.
Now, MIP versus CR, you may open somebody up in MIP and that person is deathly in pain. That's that 5%
That's
where
a joint issue.
CR versus MIP, that really becomes the conversation. But for the purposes of today, I think we can try to make it not as complex.
Yeah, exactly.
Yeah.
So I think-
Basic overview
Diagnose
so that we can talk about it.
what the issue was, how they got to where they got, look at where that they currently have, and then you have to either keep the environment, is what I tell patients, do you want me to build your smile in this environment? If I'm
Exactly.
building in this environment and you have wears everywhere, I cannot make your teeth longer. I have to either, if I'm gonna make them bigger, I have to go up, if we're talking about the maxilla, like meaning crown lengthening or gingivectomy or whatever, or if I'm talking about the lowers, I have to stay within that range, that shimbashi, that bite that they currently have. I cannot change it. Now, if I want to build something new, then now I recreate the environment. So now is when we talk about opening the bite, whether you want to do it in CR, CO, whatever the hell, you just make sure that the patient looks normal when you're doing it. You open enough to where you want contacts heavy in the back, premolars touch, canines, you put the red and blue paper and you can slide it out. And I personally don't like anything from anything on the incisors. As long as you keep to those norms and you have canine guidance when you move forward,
You'll
the
be
patient is
pretty
not
good.
hit anywhere,
Yeah.
and you don't have any teeth hitting in the, when you're moving to the right, you don't have, how do you call it, like whatever occlusion in the back. Yeah.
No.
You don't want any
Interferences.
interference,
Yeah.
correct. You want to avoid every interference.
And
then
making
you
sure
wanna-
that you're test driving this on the temporaries
yeah, the
first.
temperature
Yes,
you're going to
good
test
point.
drive it. And then when you close, you want to make sure that it's cusp to fossa, nothing on the inclines. As long as you stick to those basic terms, you're going to be fine. Now, like Vince mentioned, there's going to be that 5%. Well, train for the 95, and then the 5% when they come, like, use
how to
other
fix it.
research, you
Yeah.
know how to fix it. But as long as you keep it to the 95, trust me, like you
Bart, you got anything?
Yeah, well,
Yeah.
there's an easy way to rule it out. So, I mean, what dictates the position of the teeth, the occlusion, is the joint, the TMJ. So when the patient comes in, just put the leaf gauge in and see if you load that joint. If there's pain, you're not touching that patient unless you know how to treat that. Because then there's underlying joint pathology. So whether you're CR, MIP, that's a basic way to just rule it out. And then at that point, I mean, figure it out, because just like Vince said, the beauty of the body is it adapts.
Exactly.
So you can open them up, within means, but as long as you fall in that range,
Yep.
the body will adapt to it. The 95% will, the 5% won't. But
And you could double check it by doing a CT of the condyle if you need.
Yeah, see where
right?
it's
So
at.
it's
put it on
easy.
the bite, condiles at 12 o'clock. As long as you're sticking there, and it's not a freaking mat, like you have a range. It's not like it needs
Exactly.
to be 18.01. Like
Yeah.
it could be 18, it could be 19, it could be 18.5.
Yeah.
What looks
You know,
normal?
what looks
Yeah.
normal? Look at the face. Look at the fucking face.
And then, some,
That's
and then
it.
some of the best places to get this training, COIS, which is where Oscar and I have been trained, Clinical Mastery, Pankey, Dawson, FMR NYC. So, but at the end of the day, it's finding the patient base and what works for you, but understanding, like Vince said, simplifying it,
Yeah.
because you're going to get so much information from all of these courses that the idea is to be able to replicate that in your practice. So don't drink the one Kool-Aid, and not everything's going to work on everybody. For example, some people don't deprogram when they're doing FMR. Some people do, So it all depends on that.
Yeah,
Perfect.
with digital record keeping as well. There's different methods, especially trained in all these courses and taught how to articulate that information to a technician. How do we record keep? So there's different ways to do it, and I'm sure we can probably simplify. I don't know if you guys want to have a very brief consensus on how you like to,
I
just
think-
for the sake of this
I
episode.
think for the sake of this, we're
Well, just one record
yeah,
thing.
just one record
If
thing.
you want to make sure your technician knows how you want your occlusion, get it right on your temporaries.
Get it
and
right
you
on
just
your
say, just
temporaries,
copy,
exactly.
copy my
Yep.
scan
That's it.
in ceramic.
test
Don't
run.
get creative.
Exactly.
Copy.
Love that.
I already
love
nailed
that.
the bite.
Yep.
That's
As I
the
the
most
mentioned,
important
simplest
part.
way
Exactly.
that you can make sure it's
test
right.
driving temps, adjusting
Yeah.
this, and making sure that this is done before the finals will make your deliveries that much easier. And it'll also
Yes.
test your lab tech. Because if things
Mm-hmm.
are off later, and you told them and you have scans that show exactly how the occlusion was and now things are different, maybe it's time to get a new lab tech.
awesome.
Very
Yes.
important. So
Yep.
stay tuned for prep design and a little bit more about all these treatment planning facets that we're going to be talking about. If you guys want to ask us any questions, particularly if you've taken certain courses, if you have interest in certain courses, we want to be a resource for you. So thank you for listening and stay tuned.
Thank you.
Thank you.